All right, we are going to talk about heart failure for this video, and we're going to look at the development of left heart failure and right heart failure, and we're going to spend the majority of our time thinking about left heart failure because that is by far and away the most common type of heart failure. And then left heart failure can get kind of subdivided into systolic heart failure or diastolic heart failure, or in many cases both. So I'll discuss that in a moment. So your third homework question is to describe the pathological progression of left ventricular heart failure. You're going to continue your discussion through both sides of the heart, which will make more sense in a moment. So here's the picture that question is posted on Canvas for you in the Unit 2 module under question number 2. So here's this picture I showed you on the first night of class, which is a little bit of a strange picture, but it's helpful for our purposes here because we have we have the lungs, of course, and then you have your heart sort of opened. So this part over here is the left side of the heart, and this would be the right side of the heart. And then, of course, there's a lot of things missing here. This is not anatomically correct, but you can see your left atria, your left AV valve or the mitral valve, and then this would be the semilunar valve. And so this is showing us some potentials for how somebody could develop heart failure. So the most common cause of heart failure is the failure of the left ventricle over time, usually because it's got some sort of increased demand that it's been working against for a long time, and it's ultimately not able to do it. And this would cause what we would refer to as systolic heart failure. And systolic heart failure is, I think, most simply defined as cardiac output that is diminished due to a decrease in the contractility of the myocardium. So that all that blood, the heart, basically the left ventricular wall gets weak over time. It could be because of elevated blood pressure. It could be coronary arterial disease. It could be any number of cardiovascular conditions. But that left ventricular wall gets weak. The force of contraction diminishes. Blood remains in the myocardium. It hypertrophies, it dilates to try to compensate, but ultimately it fails. And then cardiac output is diminished. So that would be called systolic heart failure. Another thing that could cause systolic heart failure would be this, which is it's called coarctation of the aorta. So it's a narrowing it's like this abnormal anatomical condition where you see this abnormal narrowing of the aorta. We could also have the heart failing because the blood backs up into the left ventricle can be okay, but the problem could be in the atria. In this case, it could be a valve issue. This would be like, let's say like they've had some sort of a bacterial endocarditis that's affected the valve. And so the valve is faulty. And so the left atria fails, which then backs the blood up into the lungs. So when the blood backs up into the lungs and the lungs become congested, even though the cardiac output is more or less normal, that's referred to as diastolic heart failure. In many cases, as systolic heart failure gets worse, then the blood will end up backing up and congesting in the lungs, and then you have both systolic and diastolic heart failure. So those are sort of the most common causes. And heart failure, there is no cure for heart failure. This is something that we really want to stay on and get in front of. It can progress slowly over many years. It can have an acute onset. It kind of depends on the scenario. But once you reach the stage where cardiac output is affected, once we see a decrease in cardiac output, then tissues are going to receive inadequate perfusion, and organ failure is possible / likely, depending on how decreased cardiac output actually is. So as we talked about in the first night of class, the body has, a whole series of actions that assist in the compensation for heart failure. And so a working understanding of those compensatory mechanisms are really helpful for really understanding this particular problem. So in some cases, we talk about heart failure from a perspective that outlines sort of two kinds of failure, not systolic and diastolic, but instead forward and backward. And some people find this very easy, and it makes the whole situation more understandable. Other people find the terminology confusing. So the terminology isn't that important, but you kind of want to know the responses and what's driving these responses. So for forward failure is driven by a decrease in cardiac output, which is going to be sensed by the baroreceptors, which would then send that reflex stimulation, which we talked about before, to try to get the cardiac output back up. This is compensation. This is the compensatory response. And the other thing, when the blood pressure goes down, that will activate the renin-angiotensin-aldosterone system, which of course causes a bunch of vasoconstriction, including the veins, which increases venous return, and also elicits the release of aldosterone, which causes us to retain sodium and water, so increases the blood volume. So all of that is compensation for the decrease in cardiac output. So forward failure is driven by a decrease in cardiac output. And the baroreceptor response and the activation of the renin-angiotensin-aldosterone system assists that, right? That's the compensation. That is what those reflex responses, or that response is what is the attempt is to, maintain cardiac output if it's possible. Now, backward failure is looking at what's actually happening in the heart as it fails and the result of that. So with backward failure, you begin at the site of damage. So if the problem is this weak ventricle that's not able to eject the blood, we start here. And then we see this ventricle continue to fill with blood. And then we see the atria fill with blood. And then we see the congestion backing up into the lungs. And we see pulmonary edema. And then we see pulmonary vasoconstriction, pulmonary arterial constriction, to kind of try to get control of this pressure that's building up in the lung, which increases the pressure gradient that the right heart has to pump against. So the right heart then fails, right ventricle, the blood backs up, right atria, and then backs up systemically. That's kind of the classic heart failure and drives the symptoms that we see of heart failure. So we'll go through that in more detail. All right, I forgot I had these things kind of illustrated. I should have pressed the button as I was talking. So starting at the left ventricle, then affecting the mitral valve, affecting the left atria, affecting the lungs, pulmonary arterioles constrict to sort of try to mediate the pressure that's building up. That then puts pressure on the right ventricle, right atria, and then we see a systemic backup. All right, so that's the story with heart failure. So you're going to want to spend a little bit of time working your way through those steps. I'll do it one more time since I did it fast. So first you would want to talk about forward failure versus backward failure. What's happening with forward failure? Forward failure is a response to a decrease in cardiac output. And what we're going to see is an effect to the effect of this is to essentially elicit those compensatory responses, which is, to increase heart rate and increase contractility and increase blood pressure. All of these things are going to make an attempt to maintain cardiac output. Now, is that putting more work on the heart? Yeah, you bet. That's going to increase the demand on the heart. That's why there is not an easy way out of this, right? Once this happens, it sort of becomes this feed-forward cycle. But that's the nature of this particular disease. So that's forward failure. Backward failure is marching, basically tracing the disease as it progresses following the disease as it progresses. So you start at the site of damage, which almost always is going to be the left ventricle. It could be this valve. It could be this valve too, but it's somewhere in here. And then the left ventricle hypertrophies. It dilates in response to the fact that it's being stretched. Then it ultimately ends up getting overdilated and weak, and so the blood remains in here. It backs up. This valve becomes regurgitant, right? This is called functional regurgitation, when the blood regurgitates from the ventricle into the atria. And the reason why we call it functional regurgitation is because the valve itself isn't faulty, but the heart itself has been dilated to such a degree that the valve leaflets don't actually shut anymore. And then we have the blood backing up into the atria, and then we have the blood backing up into the lungs. The pressure in the lungs goes up. The lungs don't particularly like high pressure, so the pulmonary arteries constrict to try to deal with all this fluid in here. That makes the pressure even higher. So the right ventricle has to pump now into a high pressure system when it normally pressures into basically a no pressure system. So that puts pressure on the right ventricle. It hypertrophies, it dilates. This valve fails functional regurgitation here. The right atria fails, and then the blood backs up systemically. So it is a big mess. So you can kind of appreciate this really enlarged heart, and the fact that these leaflets are just not going to close because the space is too big. They've been stretched. The valve leaflets are not stretchy. That's connective tissue. It's not like they can just get longer, right? They're anchored to the papillary muscle. So when the heart gets really big, those things don't close, and the blood regurgitates back into the atria. So you'd want to definitely talk about that valve issue, but you want to emphasize that it's a functional valve. It's functionally regurgitant. The valve itself is not problematic, right? There's plenty of valve issues where the valve itself is the problem. This just happens, the regurgitation happens to be due to the enlarged heart, not the valve itself. This is what pulmonary edema looks like. This is frothy, foamy stuff. Oftentimes they'll cough up actually like a foamy, maybe even pink blood-tinged mucus. This is fluid in the alveoli down there. This is what fluid in the alveoli looks like. If you remember, that's called transudate. We talked about that earlier on in the semester. As that blood backs us up, systemically, right? So from the blood that comes to the right side of the heart comes from the liver, right? It comes from, and the liver is connected to the gut via the portal circulatory system. So the blood starts backing up all over the place, right? It backs up ultimately to the liver and portal circulation. And so, those vessels become engorged, the fluid leaks out, right? It says this hydrostatic pressure. And what you're seeing here, this is very characteristic of people with heart failure. This is fluid trapped in the abdominal cavity, right? And the peritoneal cavity. And this, they call it ascites. This is hard, right? This is hard like a drum. That's really, really tight. And so that's pretty characteristic of heart failure patients, right? They accumulate a lot of fluid. They get quite a bit of edema. And so one of the treatments for these people is big time diuretics to move that fluid out of there. Okay. So really quickly, and I don't want to spend a lot of time on this because we don't have that much time to spend on every one of these things. But I just want to introduce you to some of the other consequences that you may encounter following myocardial infarction. So not all of these happen every time someone has a heart attack, but these are options. These are things that you may see. We've already talked about heart failure. Turns out that heart failure is quite common after myocardial infarction. Then I'm going to introduce a concept called cardiogenic shock, papillary muscle dysfunction, ventricular, septal defect, cardiac rupture, including tamponade, ventricular aneurysm, thromboembolism, pericarditis, the inflammatory response, and arrhythmias. So these things may or may not occur after myocardial infarction. They may occur for other reasons as well. Not just myocardial infarction, but this is just seems to be a good way to kind of introduce them. And we're not going to spend a bunch of time on this. So again, heart failure is quite common with people who have had myocardial infarctions. About half the people who have heart attacks will end up with heart failure at some point. Cardiogenic shock is not that common. It's going to be a lot more common if somebody's had a significant heart attack. It's going to be very likely if greater than 40% of their myocardium is affected. But, that's about 10 to 15% of heart attacks are to that degree or that extreme. But if someone does develop cardiogenic shock, the mortality of that is in the neighborhood of 80 to 90%. So that's a big deal. So basically, cardiogenic shock is so severe because it kind of elicits this feed forward kind of a situation. So basically what happens what starts this process off is a significant decrease in cardiac output, and the heart's too damaged to respond to it. So they're going to see less coronary perfusion because the blood's not coming out of the heart. And then they're also going to not be able to, and in that same vein, because the blood's not coming out of the heart, it's going to back up into the lungs. So when the blood's not coming out, the blood pressure goes down, the blood's not being delivered effectively, and they're also not oxygenating their blood effectively or getting rid of their metabolic waste because their lungs are congested, and you can't diffuse gases across a whole bunch of fluid. So they become hypotensive. Hypoxemia is low oxygen in the blood, and they develop oftentimes metabolic acidosis because they can't get rid of the metabolic wastes, and that causes further, as this gets really bad, that's going to make the heart weaker, and so they're going to get even less coronary perfusion, more pulmonary congestion, and this whole thing just really spirals out of control. So that's cardiogenic shock. It's a big deal. Chances of coming out of cardiogenic shock unscathed are very unlikely. Even if someone does survive it, there's usually so much organ damage because, they're not getting blood delivered to anything. So your organs are becoming hypoxic, and you're going to get some damage as a result of that, unless you can mitigate that right away somehow. Okay, papillary muscle dysfunction is if the papillary muscle if the infarct is located in the inner wall of the ventricle and the papillary muscle actually ruptures, then that can cause valve incompetence, right? Because it's not the papillary muscle's job is to hold the valve leaflets, anchor them. So that then can cause, heart failure with pulmonary edema and cardiogenic shock, especially if it's a significant papillary muscle dysfunction. Here's a picture of this is the same picture, but you can see it close here. This whole chunk of papillary muscle, right? This whole thing is free, and that's a very incompetent valve. Okay, ventricular septal defect. This is kind of an interesting one. And so this would be the area of infarct is in this region, and then the enzymes come and they sort of clean it up, and then you end up with this hole here. So this is a VSD, a ventricular septal defect. And it's pretty interesting because you have it reduces cardiac output via the aorta because some of the blood, there's more pressure in this side. So the blood, when the left ventricle squeezes, the blood gets kind of squirted in here. So this right ventricle now has more blood than it should. So it increases the work of the right ventricle more than it does of the left ventricle, but cardiac output still is reduced. But sometimes it's hard to notice that because of all the compensation. So it can be kind of late in the game when you find that VSD. And sometimes they're really small. There is such a thing as a congenital VSD where someone's born. If you've ever heard someone being born with a hole in the heart, that's what they're talking about. They're actually, there is, in utero, there is a connection between the right and the left ventricle because, we're not breathing air in utero. But it closes up at birth, but sometimes it doesn't close up, and so then they'll have to go in and repair that. So these are some pictures of VSDs, holes in the heart there. There's Here's another one. So again, it's kind of showing you, this is the location right here. It's sort of a funny view. But so the right atria is pumping normal stroke volume. The blood goes into the right ventricle. The right ventricle would pump the blood out, but when the heart squeezes, blood from the left ventricle is pushed because of the pressure into the right side. So the overall volume of blood in the right ventricle is increased, which increases the work. So you'll see the wall of the right ventricle hypertrophy, which is weird, right? The right ventricle is usually much thinner than the left ventricle. But in this case, you can see that it's not because of this hole. So it's pretty interesting. And again, because of compensation, the cardiac output will remain normal until the heart fails, and then it will drop significantly. So of course, there's less pulmonary congestion here because the blood's not backing up, and not until just the heart completely fails. The blood's not backing up into the lungs. Instead, it's going this way. So you'll see less pulmonary congestion than you would in left heart failure, at least initially. This is another example of those enzymes eating away at that infarct. So that's a very weakened wall. So that's called a ventricular aneurysm. And every time the heart contracts, it sort of balloons outward with each contraction. And that can burst, which can cause, which is referred to as tamponade. So there's all sorts of problems with this whole setup, right? Heart failure is one, clots are another. Arrhythmias because of the abnormal dilation, that's another. And then, of course, rupture, where you get irritation because you get blood in the pericardium that's not supposed to be there. So that's obviously an emergency situation that can be mediated if somebody is right on it, right? So this is kind of the deal. This is what a nice visual of the tamponade. So you get bleeding into the pericardial sac through a hole in the heart. And of course, the pericardial sac is not stretchy at all. It's not elastic. And so as fluid fills in the pericardial sac, it doesn't stretch, and instead it pushes on the outside of the heart as well. So that decreases venous return, which would then decrease cardiac output. So you can see how that would get pretty ugly pretty fast. There's another picture of what this could look like in an actual heart that had tamponade. When this happens, because blood, it fills into the space. If they do survive it, oftentimes they'll get fibrin deposits, and it will be kind of like, you could imagine, like sort of sewing the pericardial sac to the outside of the heart. So that's very severely restricts the motion of the heart. This is a big picture of a clot, a thromboembolism. This is another picture of this is a picture of a valve problem. Oh no, I'm sorry, that's not a valve. That's a clot too. That's a clot. My dog is whining again. I'm sorry. This is asking us, why is this case more likely to lead to a stroke than a pulmonary embolism? And the reason for that is because the clot is in the left side of the heart. That's a weird view. The clot is in the left side of the heart and not in the right side of the heart. Clots in the left side of the heart go to the brain. Clots in the right side of the heart go to the lungs. There's a close-up of the clot. And arrhythmias are another issue, but I'm gonna stop this video and talk about arrhythmias in more detail in its own section. You need to